Hello, everyone. This is Amy from the New York Association on Independent Living. I want to thank you today for joining today's presentation. Today's presentation will be on the UAS and PRI Screen for transition specialists. A few housekeeping items before we get started. During the presentation, all participants will be in listen-only mode. However, you may submit questions to the speaker at any time through the questions pane. Simply type in your question and click send, and we will address questions throughout today's presentation as best we can. If they start to get really heavy on questions, we will let you know that we're waiting and holding them to the end. You can also raise your hand. If you raise your hand, I will unmute you at the appropriate time and you can ask your questions directly. Any questions that are not answered today will be forwarded by the presenters. They will follow up with you regarding those questions. You can send them to myself. In addition, today's presentation is being recorded and will be archived on the NYAIL website, and the slides will also be available on the website. Today's webinar, again, is focused on the UAS and PRI and Screen, and our presenters today are Christine Trimboli and Laura Bingell, nurses for the Money Follows the Person Transition Center, also known as Open Doors. Take it away, ladies.
Okay, this is Laura, and I'm going to begin. The reason we're addressing this is that evaluations that determine an individual's to what we all do in MFP. The UAS and PRI evaluations can qualify or disqualify an individual for waiver services, and the MLTCs are using them to decide which home-based services are covered. So many transition specialists have expressed a desire to better understand the tools that are used and the processes involved in completing and interpreting them. So Christine and I are going to address that for you today. We will first do a brief comparison of the two, and then we'll each spend a little bit of time individually on each evaluation and give you opportunity to ask questions as well. Throughout, Christine and I will be taking turns talking, so we're just going to keep you awake that way.
Okay, thanks, Laura. So, definitions, PRI versus UAS. PRI stands for Patient Review Instrument. This is a clinical tool which is used to assess a person's condition and the amount of care required for admission to an institutional setting and prior to discharge. The screen is a supplement that's done to better determine mental health, cognitive factors, and resources available. Since October of 2015, SUNY at Albany School of Public Health is now providing all training for PRI and Screen evaluators. Formerly, this was done by IPRO, Island Peer Review Organization, but now, again, SUNY at Albany School of Public Health is the contracted provider agency through the DOH. UAS, Uniform Assessment System. This is a comprehensive assessment system designed to determine the amount of care required in home and community-based settings. It includes supplements for functional status and mental health, and there are 3 separate assessments for adults, children 4 to 17 years, and 0 to 3 years. The use of the UAS began in March of 2013 with the goal of utilizing a comprehensive community assessment system for 8 Medicaid services: adult day health care, assisted living, care at home 1 and 2 waivers, which are part of the OPWDD system, managed long-term care, long-term home health care, personal care, CDPAP services, and both the NHTD and TBI waiver services. The UAS New York contains a single unique case file for each individual enrolled in one of the New York State home care-based service programs owned by the New York State Department of Health. And with this information being accessible by all local social service and health provider organizations in New York who require access to it. The information entered into the UAS New York is immediately available to other organizations serving the individual, and the intent of sharing this information at this level is to facilitate communication among organizations and ensure both continuity and quality of care.
Okay, so now we are on the who does it slide. The PRI is a registered nurse. The State Department of Health calls this particular nurse a nurse evaluator. And it can also, in portions of the screen portion of this evaluation, be a qualified social worker. And they're qualified through that contracted program that Christine had just mentioned that's now SUNY Albany. The UAS is also a registered nurse assessor, although there are certain portions that a social worker can contribute to. So there may be one or more contributing people on the UAS, but completed primarily by the RN. And this person is qualified through a web-based training on the New York State Department of Health website. So a screen is the home and community-based assessment portion separate from the PRI that includes questions about living conditions and environments, and we'll get in more depth in that as we go. Some agencies that retain trained personnel are hospitals. I'll let you know when to go ahead. We're still on the previous slide. Hospital discharge planners, nursing homes, certified home health agencies, RHCFs, county health, public health departments, local department of social services, some ILCs and MLTCs, and some other utilization review personnel. The PRI portion has to be the RN, and the screen can be an RN and a social worker. And as I mentioned, there may be more than one contributor to the UAS, just to recoup that. Okay, please, next slide.
Okay, where are each of these conducted? The PRI is usually done in the community while someone is hospitalized or on a swing bed status. Swing bed status often refers to someone receiving ALC, alternate level of care, while they're awaiting available placement or appropriate discharge planning, and prior to leaving the nursing home. New York State requires a PRI and screen for skilled nursing facility admission to determine appropriate level of care. Medicaid will pay for these, and while Medicare will not. Many people or families will often have to private pay if they do not have Medicaid to have a family member admitted to a skilled nursing facility, and these PRI charges vary widely. Also required are nursing home assessments such as the minimum data set, known as the MDS, and outcome and assessment information set, which is referred to as the OASIS, are still required. Also of note is a PRI is good for 90 days as long as the individual's health or medical status has not changed. So for the UAS, these are conducted in the community or in a facility prior to leaving, and they can be used by MLTCs and the RRDC, Regional Resource Development Centers, for waivers to determine if a minimum level of care is met. Having a UAS done in a facility, and some of you transition specialists have encountered this, can be very difficult to obtain. One, because there are usually no trained staff within the facility to complete them, and for an agency like a CHA, a community-based agency, they would have difficulties entering a facility because billing for the individual, when the individual is already receiving services in-house, and they cannot bill for additional services under CMS regulations. It would be like someone being classified as an inpatient and an outpatient in the same day.
Right, and that's why we included this website address at the bottom for anybody that wanted a little additional information. The Department of Health had issued a statement that would cover people that were being discharged and had to wait for their home evaluation to be done if they needed immediate personal care. So what this was titled was Reminder of Expedited Authorization Process for Medicaid Recipients with Immediate Need for Personal Care Services. What it does is it gives authority to the local Department of Social Services to authorize personal care services for up to a 30-day time frame while they're waiting for their evaluation to be done in home. Okay, next slide. So this just shows in a little different way to give a visual of what individuals need according to their settings. The PRI for the nursing home resident, we start at the top, would be good for 90 days, as we mentioned, and would need to be submitted to the RRDC with the waiver application. And it should be done by certified staff at the nursing home facility. It is the service coordinator's responsibility to request an evaluation, even in the setting, if they know they're going home. Waiver participants, the UAS would be completed by the nurse evaluator, typically the CHA or the LDSS, within that 90-day time frame of return home to the community. And it is the RRDC's responsibility that the evaluation is completed and reviewed for accuracy. So the MLTCs are all using the UAS now, and that was official. Everyone had changed over to that as of February 2014. And Christine and I can help you with the PRIs and interpreting them when you get them. We would just need to see them and help you to determine where this person will fall in their anticipated nursing facility level of care. You usually have a pretty good idea, even though you may not know the exact number, and we can help you do that. So when using Maximus for the conflict-free resolutions, it's just interesting to note that you may find you'll have 2 UAS evaluations done by 2 different evaluators within a very short time frame, because Maximus will do their own, and then the MLTC that the consumer chooses will do their own once they take that person on their services. Next slide.
Okay, how do we measure outcomes? We measure outcomes through CAPS, RUGs, and nursing facility level of care, known as NFLOC. CAPS are clinical assessment protocols, and they assist the assessor to interpret systematically all the information recorded on an instrument. They help the clinician focus on key issues identified during the assessment process so that decisions as to whether and how to intervene can be explored with the individual. RUGs, our resource utilization groups classification, flows from the MDS, which is the minimum data set, which is the evaluation conducted in a skilled nursing facility setting and of interest. It's the same evaluation that the Section Q referrals come from. These determine facility level of care and justify overall staffing levels based on a case mix of the facility. NFLOC, for nursing facility level of care, must be a score of 5 or above for someone to be eligible for one of the waiver services. The MLTCs also use the minimum level of care score of 5 as criteria as well. Next slide.
So to focus on these each just a little bit more, the clinical assessment protocols are key factors in an individual's life that would require additional needs and support. So the areas of focus are their functional performance, cognition and mental health, social life, and clinical issues. And there are 22 different CAPs that are assessed. To focus in a little on the clinical issues, because these are clinical, and you could also think synonymously with some medical issues. So we would have frequencies of falls, pain, pressure ulcers, their cardiorespiratory status, nutritional status, hydration, feeding, if they use a feeding tube, medications they're on, substance use, toileting, mood behavior, informal supports, chronic disease, and whether they need clinically complex care. Multiple triggered CAPs can identify for evaluators an area of particular vulnerability, and this helps to determine the level of care better and to formulate a better plan of care with the goal of resolving these problems or reducing the risk of decline and increasing the potential for improvement. Next slide.
Okay, so now we have our RUGs, which again are resource utilization groups. RUGs are comprised of 7 categories and 23 groups. RUGs are major classifications that people are assigned to based on clinical characteristics, functional status, complexity of care needed, and cognitive status. The primary purpose of assigning a RUGs category is to calculate the relative cost for care in a facility. The score is based on how an individual was able to complete the tasks that are represented in this RUG group 60% of the time during the previous 4-week time period. An individual with a lower score being more independent, and one with a higher score reflecting a heavier need for assistance and thus more resources. However, the RUGs no longer drive nursing home compensation, but it's still helpful for nursing homes in their fiscal planning and staffing determinations. Next slide, please. Okay, this slide may be a little difficult to see. I'm sorry in advance for that. But this is an example of a RUGs classification system showing in a flowchart type of format. This chart combines the 5 health categories and numerical ADL scores, which are derived from that smaller chart in the lower left-hand corner of the slide. That shows the ADL point conversion. Information is translated from this chart into a letter and number score, for example, PA3 or CB6. So if you look under reduced at the bottom, reduced physical functioning, I had just mentioned PA3, that shows what their score is by using that point conversion chart in the lower left-hand corner. They're assigned certain point values for how much assistance they need in eating, transferring, and toileting, for example. So starting at the top, rehab is based on the number of hours of therapy each week that is required and the different disciplines involved, such as PT, OT, and speech therapy. It needs to be clarified if the therapy is for maintenance or restorative purposes. To be considered heavy rehabilitation, it must be for restorative rehab. For example, of some of these qualifiers would be the sessions would need to be private versus in a group setting. There would have to be a physician's order and a specific care plan for someone to be classified under heavy rehabilitation. there also would need to be documentation indicating actual improvement in functional ADLs, as well as show positive potential for improvement. Going down to, so if they don't meet heavy rehab, you would look down below in special care. You'll see some of the examples next to that, such as someone who is comatose, who has a level 4 decubitus ulcer, also known as a bed sore, or someone who is a quadriplegic. Again, just a few examples in that category. If they don't need special care, we would look down further to the clinically complex section, and someone, for example, would be someone requiring oxygen therapy daily, not just a PRN order, someone receiving dialysis, or someone with a current diagnosed urinary tract infection receiving active treatment. If they don't meet any of those qualifiers or categories, you would then look down to the severe behavior section. Examples in this area would be someone showing verbal disruption, physical aggression, disruptive or infantile or inappropriate behaviors, or having hallucinations. And again, these would need to be documented. And last but not least, if someone does not meet that prior category, would be someone who's in what's called the reduced physical functioning. And this is actually where a good majority of people end up being. They don't meet the previous categories, but they can still have varying levels of need for assistance with their ADLs, such as bed mobility, transferring, using the toilet, commode, and eating. And next slide, please.
Nursing facility level of care is a score that is automatically calculated with the UAS assessment when it is done. The computer system runs it through an algorithm, and out comes the number once you've answered all of the required questions. And the assessment portions that are used to calculate this number are cognitive, communication, vision, mood and behavior, functional status, continence, and nutritional status. And basically, the higher the number, the greater the level of care that would be needed. So 5 is the cutoff number. Anything below a 5 is not considered eligible for long-term care services in or out of a nursing facility. And average for MLTC enrollees in New York State happens to be a 16.4, to give you kind of an idea of where people fall. But it's not unusual for a nurse assessor to get a nursing facility level of care anywhere from a 4 to a 25. And I know personally I've gotten a 27, and Christine has gotten a 30. And when we spoke with people at the DOH help desk for UAS, they said it's possible to get as high as a 48. So I'm not sure I'll ever see it, but it's kind of nice to know where the upper limit is. Next slide. So now we will focus particularly on the UAS. And go ahead and proceed to the next slide, please. The UAS purpose is to evaluate the individual's strengths and status, and it guides in the development of the plan of care. It's designed to be a comprehensive, complete, and accurate evaluation that takes a holistic approach to the individual's care. An accurate UAS depends very much on good assessment skills, good interview skills, and good professional judgment of the evaluator. So in the end, it would improve the person's outcomes and ensure that the individual's receiving the right care within the right setting at the right time. And as we mentioned before, information that is put into the UAS system is available across agencies, anyone that does have that person assigned, so that we have access to the same information. Next slide. The process is interview and observation, and often consultation with as many people as you can, actually, to get a good picture of the person. So family members, the primary care physician, other caregivers, if they already have personal care aides. Christine and I discussed this. If the service coordinator is working with them already, or somebody in ILST is seeing them, they can give you a good idea of what the person is doing and where their needs are. So we focus on whether the person is actively managing tasks of daily living, not whether the caregivers think or believe the person might be able to do it. What we want to know, as is bolded in the bottom, is what is the person's actual performance. And built into the assessment instruments are the series of research-based algorithms and formulas that generate the assessment outcomes and reports to support the care planning. Most UASs must have a doctor's order to complete them, and because of this, the assessor is in a position to communicate with the doctor's office, and we can confirm their status, review medications, review medical documentation, and even call back afterwards if we have concerns that we want to be sure their primary doctor is aware of. But I can't stress enough that people sometimes will not accurately report their own ability, and a caregiver's input is really essential in helping the evaluator to determine their actual ability. So observation includes making a skilled judgment that what the individual is telling us is in fact their true level of ability. And Christine, you had
definitely here. Thanks, Laura. For an example of this is it's fairly common with our TBI population to overestimate their capability in certain areas. For whatever reason it is, they may not have the insight to recognize their deficits, but we touched upon this a bit for those of you who were part of the Bianni's presentation for traumatic brain injury. So just something good to keep in mind, especially with the TBI population, is they can overestimate their capability. Next slide.
Next slide, please. So areas that are evaluated in the UAS are cognition, and that's broken into short-term and procedural memory. So example of short-term could be, what did you have for breakfast? Can they recall recent information? And another tool that nurse evaluators used is giving them perhaps 3 words at the beginning of their conversation: dog, pencil, desk, asking them to remember them, and then saying, now what were those words that I asked you to remember? And seeing if they can recall them and bring them back to their mind. Procedural is more asking to complete multi-step tasks, like pick up the pencil, place it on the table, and close your eyes, or whatever you would want to say, but it would have to be multi-step to see if they can remember the procedure. Typically the procedure does make a little more sense than the example I just gave you. So communication, vision, mood and behavior, functional status, which includes ADLs, IADLs, and mobility. And primary mode of locomotion is also considered, which includes indoor locomotion, their activity level, a change in their status, their overall self-sufficiency, and even considered if the person is capable of driving, if they drive themselves, or what mode of transportation they use outside of home. And then the other two as well, continence and nutritional status. Okay, next slide. Components of a UAS are broken down this way. The major portion is the community assessment. When a community assessment is completed, additional assessments may be indicated, and any supplement that's indicated should be completed on the same day. The functional supplement, as noted here, includes an expanded set of functional and clinical items, including more in-depth review of cognitive skills, daily decision-making, activities of daily living, including bathing, performance of personal hygiene, and it breaks it down more specifically into performance of these tasks and ability to perform these tasks. So again, the actual as versus the capability. The mental health supplement includes expanded diagnoses, symptoms, treatments, and life experiences. The items that trigger the mental health supplement are disease diagnoses of schizophrenia, any health conditions that would qualify as psychiatric, marked for abnormal thought process, delusions, substance abuse, depression, and any cognitive performance items. If these are not triggered by the algorithms in the assessment, it is the discretion of the assessor that we may include these if we feel that they would be helpful or feel that they are necessary. And I know that when Christine and I discussed this, we said we often do that, especially with the functional portion, to be sure that the person's snapshot really shows what they need assistance with. So a little more in depth is not necessarily a bad thing. Okay, and we can.
Laura, I do find myself doing those additional supplements, especially if there's someone that I'm feeling is not being captured adequately from the regular community assessment. So I actually do this fairly frequently, more with a functional assessment, but occasionally with the mental health.
Yeah, I agree with you. I do the same. Okay, next slide, please. This is what the coding choices related to the functional assessment may look like. What is their level of ability? And you can see it goes from independent and then proceeds down to someone who is in a coma or unconscious, so would need entire total assistance to do any ADLs or IADLs. So there's a variety there of choices in between. And you'll see in the next slide how this is broken down. Go ahead and proceed to the next. Thank you. So for this one here, this particular is meal preparation, and you see the top is the performance. So as I have in the white box there, it's what the person has actually done in the last 3 days. So the extensive assistance, it goes out and tells you exactly what you're looking at. Help throughout the task, but performs 50% or more of the task on their own. So it does give an indication as to what each of these different answers might really entail. Maximal being less than 50% on their own, total dependence, or did not occur. Meal preparation, perhaps they didn't do any of their meal preparation. They have it done for them entirely, or maybe they were in the hospital, or maybe they're on tube feeding, but for whatever reason that needs to be there because it may not have happened in the last 3 days. So meal preparation capacity, and you see how there's a difference there. What was actually done for this particular person was they needed extensive assistance, or they had extensive assistance, but what they really need is setup help only. So this is where the good assessment skills come in as well. Why was there a difference? Was the caregiver more helpful than they needed to be? Was the person depressed and not wanting to do what they were capable of? So sometimes a little extra digging is needed there to get a good, accurate answer. And this really does impact the outcomes in the end. Wouldn't you agree, Christine?
Yes, definitely. The accuracy of these answers, the accuracy of answers to these questions really impacts the level of care outcome. And again, just driving home the point, for example, someone's performance can be temporarily limited or impaired due to an exacerbation of a medical condition, while their overall capacity in general is greater.
Ah, good point. Next slide, please. For the mental health supplement, the indicators that are looked at are listed there for you. Things that might be noted: self-deprecation, expressions of guilt and shame, irritability, hopelessness. I can let you read through the rest of those as well. Concern by family, stress or trauma. We actually ask the people, have there been any major stressful events in your life recently? And just let them tell us. Family conflict, the number of medications, tendency toward violence, or even police intervention. So, you know, we may be asking them about the police, and that'll come up in the next slide, so go ahead and proceed to the next one. We may ask them specifically, when was the last time the police responded to your home because the neighbors called them? Never? More than a year ago? 31 days to 1 year ago? In the last 3 days? And, you know, some of these answers, as we mentioned with the other as well, with the mental health, it's going to give you an idea of, is that person safe at home? Are they a risk to themselves or others? And that will come out in these evaluations through the questions and the built-in algorithms. Okay, next slide, please. Now, here's an announcement from the TBI Services Coordinating Council, and most of you were already aware prior probably to this presentation that we had mentioned that for TBI waiver, the person needs to have the UAS and the PRI done. They still want to have both, and this is why. This was the announcement they made in June. And I'm going to read it out because it really is pertinent. There is great concern many of New York's most vulnerable citizens, those with a documented traumatic brain injury, TBI, whom are currently being served by the New York State Department of Health TBI waiver, will be inaccurately assessed as not meeting level of care criterion, particularly if their primary disabilities are cognitive behavioral and not physical. So it really is true that when you're functioning on physical abilities, sometimes people who need to have more supervision might be overlooked. So in their efforts to be sure that their people are taken care of, that's why both are still required, to be sure that we're getting an accurate picture of their areas of needs and they're not denied services that they do need. And in the next slide is another community that had similar concerns, the Alzheimer's Association, and for similar reasons, because Alzheimer's sufferers may be very physically capable or able. And Christine and I talked about this and kind of, you know, laughed about in a not a funny way, but the fact that I have taken care of people with Alzheimer's that run a lot faster than I do. So they would be out the door and they still need their supervision and you're trying to catch them, but there's nothing physically wrong with them. But it doesn't mean they don't need our assistance. So the Alzheimer's Association has the same concerns. And as a result of this, there does continue to be training, and the DOH is really doing a good job in being sure. We recently had additional trainings to maintain our UAS, our ability to do UASs, to improve our abilities in assessing cognitive impairments. So we're constantly getting new education, and it's just our goal to be sure that we don't miss important areas as the two that we just mentioned. So, anything to add to that, Christine?
No.
Okay.
I cannot think of anything at the moment.
Okay, then ready, set, go. We'll go to the next slide, and Christine is going to focus for you on the HCPRI and screen.
Okay. Next slide, please, Amy. So, what is a PRI? The HCPRI is the Hospital and Community Patient Review Instrument. This assessment tool was developed by the New York State Department of Health to determine level of care and appropriateness of placement. It also assesses physical, medical, and cognitive characteristics and determines selected services. Again, as touched upon in our earlier slide, the PRI no longer determines facility reimbursement for the care provided, but again, it's useful for fiscal planning in the nursing home and staffing. Previously, the more care or complexity of care a patient required was directly related to the reimbursement received from Medicare and or Medicaid. Next slide, please. So, the sections of a PRI. There are 7 sections, as you can see, outlined above. Administrative data, medical events, activities of daily living, behaviors, specialized services, diagnoses, and plan of care summary. The PRI is encompassed over a total of 4 pages of documentation with these 7 sections included. Next slide, please. So, how does a PRI work? The category defines medical conditions and treatments, the need for rehabilitation, and if there's mental health and behaviors that need to be taken into consideration. The scoring, so once you have your category, the scoring reflects how much assistance or supervision is required within that category for their ADLs. So a completed PRI and screen generates a category. Think back to that yellow chart starting with heavy rehab, going down through the different levels down to the lowest reduced physical functioning. So again, the PRI and screen will generate a category and numerical score. Next slide, please. Okay, so this is just one example of ADLs, and this scoring is involved with the task of eating. So it looks at how the individual consumes their food, their level of independence while eating, how they maintain their nutrition. Do they need verbal cueing? Do they need assistance opening containers or even cutting up their food? So the client is observed to determine if there are any special considerations for the level of assistance so that the meal will be eaten. Does the client need to be fed totally by staff? Does the client perhaps require tube feedings? And if so, are they independent with this? And if not, to what extent do they need assistance? Do they just need someone to set them up, opening their cartons or containers for them, or perhaps cutting their meat? Or perhaps do they just need some encouragement or food placed on their utensils, but they're able to then bring it to their mouths? So this just gives an example based around eating, what's involved with scoring. Next slide, please. Okay, now we're going to talk about scoring as related to transfers. So we start with, is there any physical assistance required? Are their transfers independent? Is only intermittent supervision needed? Do they need assistance for guidance, safety, or steadiness? Are they totally dependent on someone else in their transfers? Down to, do they need equipment and what type of equipment? Starting with a higher level of need, someone needing a Hoyer lift, to maybe someone who just needs someone assisting them with a gait belt. Transfer is the act of moving between positions, to and from the bed, to and from the chair, car, or to a standing position. Perhaps most surprising in the PRI and scoring is that mobility or ambulation is not directly factored into the score. Now that, I'm sure, is very surprising to you all of this.
Yes, I thought about that too, Christine, and the more I thought about that, the more I wonder as if when the PRI was designed, it was primarily for placement into nursing home facilities, not so much to get people home. So as our focus gets to be more and more on returning people to community living, then rightly we need to focus more on mobility and not just how many people they need to transfer. But to me, it really just highlights that still we're in a position where there's no one tool that can be entirely accurate in every situation.
Yes. Next slide, please. Okay. Here's an example of scoring around toileting. So we start with the ability for someone to be able to get to the toilet, bedpan, or commode, their ability to maintain their personal hygiene around toileting, their ability to appropriately adjust their clothing, assessing someone for continence or incontinence, whether they need to wear incontinence briefs or pads, and if they're on a toileting or bowel regimen. Some individuals require a toileting schedule to remain continent. So for instance, they may be placed on the toilet every 2 hours and given the opportunity to eliminate whether or not they do. So that's what a toileting or bowel regimen really means. Next slide, please. This slide again is just representing the different categories or special needs group that we saw earlier in the yellow flow chart, starting with heavy rehab. If you don't meet that criteria, it could be special care, down to clinically complex, severe behavioral, or again ending at the bottom with reduced physical functioning. Once an ADL score is added up, the individuals are assigned again to one of these 5 special needs groups, factoring in the score and medical clinical conditions. Next slide, please. Okay, so we're going to look more in depth with heavy rehab at the top. This is someone requiring restorative, PT, OT, and also speech therapy should be on there. They need a minimum of 5 sessions a week to be under this category, with a minimum of 2.5 hours a week. These 2.5 hours a week can be combined between the different therapies, and they must be likely to improve. Special care underneath heavy rehab would need an ADL score of 5 or more and have 1 or more of the following conditions. They may have a stage 4 decubitus, they may require suctioning, they may be comatose, they may require special feeding by a nasal gastric, parenteral feeding, or they may be a quadriplegic or have MS, multiple sclerosis. Next slide, please. So again, not meeting the criteria for the prior categories brings us to clinically complex. They have an ADL score less than 5 and one or more of the following conditions. They may have a diagnosis of dehydration, internal bleeding, daily oxygen, and again, this is not PRN oxygen. They may require dialysis, be diagnosed with a terminal illness, need 1 or more MD visits per week for an acute issue. They may require wound care. They may have a stasis ulcer. They may be receiving chemotherapy, blood transfusions. They may be in active treatment for a urinary tract infection or have cerebral palsy. Again, these would all be measured over the past week or documented needing continued care for the next 7 days with a provider order. Next slide, please. Okay, next down in the flow chart is severe behavioral. Again, they do not meet the prior criteria of clinically complex. So this would be someone who exhibits behavior such as infantile, disruptive, verbally or socially inappropriate behavior, or physical aggression. The behaviors must be documented, and they have to have occurred at least once per week for the past 4-week period in order to be classified under severe behavioral. And if we can't meet severe behavioral, at the bottom of the chart is our reduced physical functioning category. All remaining individuals who did not meet prior criteria are here. And this care and the needs in this group tend to be more custodial, and they can often present a challenge for appropriate placement.
Mm-hmm. Yes, we discussed this, and Christine and I actually evaluated each other, and we both fall into this category of reduced physical function. But when we interview each other, even though our numbers are the same, we would be the same. What was the category, Christine? We were CB?
Oh, like the lowest, PA3.
PA3. So we both were PA3, and yet where we need assistance is different. So even though we fall into the same category, you still have to look at the individual.
Okay, next slide, please. So, what is a screen? So, we have our PRI, we have our screen. The screen validates the level of care that's needed, the qualification for nursing home placement, qualification for home care-based services, and it also validates the need for supervision and oversight based on someone having the diagnoses of dementia and or Alzheimer's. Next slide, please. There are 2 purposes of the screen. One is to determine the potential for appropriate care in a setting other than a residential healthcare facility, and to assess those recommended for RHCF for possible mental illness and developmental disabilities, which would then require additional review instruments. Serious mental illness means the illness meets very extensive and specific criteria as laid out in our instruction manual for people who are qualified to do PRI and screens. They require additional screening and further evaluation. At that point, a level 1 and or level 2 review would then be done to ensure appropriate placement. The screen can also trigger something called a community-based assessment. Next slide, please. Okay, a community-based assessment that may have been triggered serves the purpose to determine resources available to an individual that would support them living in the community. So it factors in their environment in the community, their informal supports, their economic resources, as well as their physical and mental needs. An actual visit to an individual's home is not always required to complete this assessment and is often left up to the professional judgment of the individual completing the screen, as we may have received an accurate description of the home environment. A nurse generally gets good at having a feeling for whether or not they're actually laying eyes on the environment, and the nurse evaluator will then continue to the care recommendations or plan of care if they feel the individual can safely receive care in the community, or if they feel the individual cannot receive care in the community, with an approximate summary. This summary could be, for example, this RN recommends continued involvement in the TBI waiver, which currently is meeting the client's needs with the service coordination and participation with the ILST, just as an example. Next slide, please. Okay, so we're at the end of our presentation. We have included the New York State Department of Health website link so that you can actually see what the PRI and screen forms actually look like with the different sections. And we thank you guys for joining in today. Hope it's been helpful for you. We'd also love to get some feedback if you have a preference or like when we do, this is our first joint presentation where we've broken up the subject matter, each covering certain sections and incorporating more of a dialogue back and forth between us. So if you have any comments one way or the other, if you'd like to see this format continued or anything in particular, you can address that to Amy, Laura, or myself. Laura, do you have anything you want to add?
No, I don't, unless anyone has questions they'd like to ask.
Oh, okay. Oh, I do see a question pop. Somebody's hand is raised. Hold on one second. Find out who it is. Okay, Jerry, go ahead. You're unmuted. You can ask your question.
Thanks. I noticed that tobacco use is supposed to be a flag for mental health issues. I found that rather interesting. Why is that? Awful lot of people that could apply to.
Well, yeah, okay. So that leaves you to question that, doesn't it? But as I mentioned, with the UASs, it was broadly researched and worked into the algorithm. So it's not the entire formula, it's just a portion of it. People that do tend to have one substance that they use would likely be more likely, I would say, more likely to use another. So it's just building on that continuum. So it's not in and of itself that it triggers that, but in relation to the other questions as they're answered. Does that help? Make you feel better?
I see. Yes, with people who've already gotten to that, sure.
Yeah, and it's not so much use as abuse of substances. So you also interview as to amounts. You get pretty personal with people. You really do.
Yeah. Of course, a chain smoker could fit into that, but I'm not going to belabor the point. But I get what you're saying. I've known more than a few.
All right. Thank you, Jerry. Anybody else? Any questions? Okay. All right. We have a question from Monique. Monique, you're unmuted. Go ahead and ask your question.
My question is, as the transition specialist, are we allowed to ask to see the PRIs and screens?
You want to address that, Christine?
Well, are you allowed to access them? If you have a signed release on behalf of the client that you're working with on the transition plan, it is something that you could ask to review. You might find it interesting to see, where they're scored. It would be the same thing as you asking to see what their score was on the UAS. Did they meet the minimum level of care of 5 or score higher? So again, with both of those, having the signed release, and it could be left up to the judgment of the RRDC, but actually the individuals that you're working with have a right to request a copy of their PRI and screen or a printed out level of care report from their UAS.
And if I just can add to that, Monique, definitely if you're working to transition somebody out of a facility, I think the more information that you have, the better. So if you can get a copy of the PRI and screen, even if it needs to be updated, what have you, I think it's a very good tool to use to see, what you should be looking at as far as do they meet waiver qualifications, what will they need from the waiver, what have you. So I definitely would encourage you to review the PRI and screen for any transition that you're working on.
Okay,
and if
thank
I
you.
could add to that too, is that if you do get a PRI and screen and upload it into the database, then it is available to Christine and I that we can remotely review it and help you with it.
Absolutely.
Excellent, thank you.
Yes,
Okay. Any other questions? Okay, it looks like the questions have all been addressed. I'd like to thank you all for attending the presentation today. Once again, it will be available on the NYAIL website, as will the slides. And if you have any questions that you didn't feel comfortable asking here on the presentation, you can certainly send them to my attention or to Laura and Christine directly. Thanks very much, everybody. Have a great day.
thank you.